All right, you guys ready? Brett, you all set? Okay. Well, good morning, everyone. I want to welcome you. My name is Darren Yesser. I am a program analyst with the Screenwise program. I have had the pleasure of working and helping out with Public Health Week this week. A lot of great events. I encourage you to check out the schedule. It's online and go to everything you're able to go to. A quick reminder to sign in if you haven't already signed in. And if you have one of the passports, I'm happy to sign that on the way out as well. So today I think we're just going to start with quick introductions. It's going to be a little tight on time. We have 3 great presentations, so I will let you guys introduce yourselves, and I'll do a quick summary of what we're going to hear, and we'll get started.
My name is Alyssa McLean. I'm a public health educator in acute communicable diseases.
I'm Sheila Johnson. I'm the Youth Sexual Health Coordinator.
Hi, I'm Becky Steele, and I work with the WIC program doing research and evaluation.
Hi, I'm Laura Chisholm with the Injury and Violence Prevention Program.
And I'm Matt Lather with the Injury and Violence Prevention Program.
So today's event is going to highlight the work of 3 different public health programs, from the use of plain language in communicable disease to the mapping of sexual violence prevention efforts to how the WIC program is making their services more culturally responsive. What you'll hopefully find in common is how the tools presented empower local communities. I'm going to start with Alyssa.
All right. Thank you. Okay, so I am going to talk to you about plain language. I think this is a really great concrete tool that we can all use and implement into the work that we do every day to help make the resources and materials that we're providing to the community a lot more approachable. So health literacy is a really important concept when we're talking about plain language. So just starting with a basic definition of what health literacy means is the degree to which individuals have the capacity to obtain, process, and understand basic health information needed to make healthcare decisions. So people need to be able to find the information that they need. They need to be able to read it and understand it and know what to do with it. So to start us off, I want to tell a quick story about my grandparents. About 7 or 8 years ago, they were living in a rural town on my aunt and uncle's property, and things were pretty simple for them. They spent their days playing with grandkids and family, reading, writing books on family history, doing all the things they enjoy. Kind of seemed like this was just going to be what they did for the rest of their years. But then one day, everything changed for them. My grandma was home alone one afternoon, and a light in the living room burnt out. She figured she could take care of it herself, pulled a dining room table, chair into the living room, and she climbed up on it, and it flipped, and she fell. She's 78 years old at this point, and she was paralyzed completely from the waist down. So pretty huge game changer for them, and they have enjoyed pretty healthy lives up until this point. But now, like immediately, their ability to navigate the healthcare system, access benefits and resources, had an immediate and direct impact on every single moment of life. And so my grandparents are white, they're educated, they speak English as a first language, and they struggle a lot. They struggle to understand how to manage all these residual health impacts that my grandma's experienced, having to manage her weight, high blood pressure. She had a bypass surgery back in the 90s, and so now she's like constantly worried she's having a heart attack. She's been at the ER tons of times because of tightness in her chest, and every time it's because she's not managing her blood pressure appropriately. So she's not getting the information that she needs in a way that she can understand that enables her to get the care she needs and to take care of herself appropriately. So this is just one example, and I tell you this because even as educated, healthy people, navigating healthcare and accessing information about our health can be really challenging and it can be confusing. So add to that maybe not speaking English as a first language, or having a learning disability, or having something really stressful happen, like becoming paralyzed, or finding out you have cancer or diabetes, or you might have been exposed to meningitis. Like there's all these things that happen that really can have a huge impact on our ability to obtain, process, and understand basic health information. So something that we could do is prepare information in a way that's understandable to people. This is a study that was done in 2003 on the health literacy of Americans, and they looked at all Americans, measured the health literacy, and put them into these 4 basic categories. So people with the below basic, basically what they could do, just to give you some context, is they could circle the date on an appointment slip, a medical appointment slip. The rest of it doesn't mean that much to them. People in the basic category are able to look at a pamphlet on a certain disease and give a couple of reasons why a person who maybe isn't showing symptoms should be tested for a disease. Intermediate category, you can look at a chart of childhood vaccines and give the age range that a child should get a particular vaccine. And then proficient could look through a complex document and find the information that they need to define a medical term. So those are kind of the categories, and this chart shows all Americans. So that's 36% are at or below that basic health literacy level. That's a huge chunk, and that's a significant portion of the general public that we're reaching out to. I thought this was an interesting chart as well, broken out by health insurance type. It's like 57 to 60% of all the people who are receiving Medicare and Medicaid are at or below that basic health literacy level. And I feel like, as state public health, I feel a certain responsibility to this population. Like, these are the people who are really counting on us to foster a system that empowers them and enables them to achieve that optimal health that we're striving for. So how do we do it? How do we provide information in plain language? These are the 5 basic steps to writing in plain language. So first of all, you want to just figure out your purpose. Why are you preparing this information? What do you want people to be able to do with it? And who is it for? And then what are your key messages? What exactly are you going to try to say? From then, you arrange your messages in order of importance. So most important stuff comes very first, down the line. And then we actually write it in plain language, and I'll get into how to choose what words you're using when writing. And then the last 2 steps there, adding organizational aids and designing the format, are just really great tools to use to make the overall content a lot more appealing and easy to digest. So OHA has given us specific guidelines, so when we're thinking about our audience, who the information is intended for, anytime we're providing information to the general public on health information, should be aiming for a 6th grade reading level. General audience, 8th grade. Communications between ourselves and DHS is up to a 10th grade, and then for experts is a 12th grade reading level. And I will point out that OHA wants us to use the Kincaid readability test. So how do you actually figure out what grade level your writing is at? There's these testing tools. This is my favorite one. This webpage, fx.com, is one you can just copy and paste your information right into there, and it'll spit out what grade level it's at. But the tests have a lot of limitations. Basically, all they're doing is looking at number of syllables in a word, words in a sentence, and sentences in a paragraph. So that's good. It's helpful for getting you a general idea of where your content is at, but it's not always super great, because there could be a single syllable word that you can read and pronounce but might not know what it means. And that's why it's also important to understand your audience, because there could be longer words that is going to be perfectly clear to them. So it's an art, not a science, and these are helpful, but they don't necessarily give you all the information you need. So when we're actually writing in plain language, it's important to think about word choice, using common words. I like to think about how would I describe what I'm trying to say to a person who's not familiar with the content. You know, we're so ingrained in the work that we do, the words we use are so common to us, but thinking about someone who doesn't work in public health, who doesn't access healthcare very often, thinking about how to provide information in a way that they're going to understand. Using personal pronouns is really useful for making the content a lot easier to read, a lot friendlier, and it shortens things up a lot too. And then active voice. An example of this could be something like CME credit will be distributed by the Oregon Health Authority by the 15th of the month. Could say, we will distribute CME by the 15th of the month. That uses an active voice and personal pronouns, and it's a lot shorter and easier. And then finally, thinking about translations and culture, the simpler something is in English, the easier it's going to translate to other languages, and more understandable it's going to be on the other side. And also thinking about culture. Idioms are really great to avoid. There's a lot of things that we say that are very culturally tied, like ballpark estimation, or things like spread the word or reach out. What is that going to mean when it's translated into Cantonese or something? It's probably won't mean very much. And then formatting is a great tool. I think you could take a body of text without changing any words and reformat it and make it 100 times easier to read. So again, putting things in order from most important down to least important. Using really valuable, useful headings and subheadings, because people do skim and they jump around and they try to find what's relevant to them, and headings can be really useful for that. Headings and chunking things together into common themes to make sure people are able to find the content that they want. Bullet points are great. Basically, anytime there's more than 2 commas in a sentence, I make bullet points. It helps people find what applies to them, what's important, and it adds white space. White space is not dead space. It's actually really valuable when we're thinking about writing in plain language. It helps make, it's easier on the eyes to just not have a wall of words, and it helps make things better, more easy to digest. And then also adding visuals, like helpful, clear images that just describe the message that you're promoting, and things like little icons of a phone or envelope by the contact us helps draw those points out. I just want to touch really quickly on experts. I think we in public health, there's a lot of very, very smart people here, and we communicate with a lot of very, very smart people. So sometimes we feel like we could just write however we feel like writing. But experts, though they can read quickly and have wide vocabularies, they have a lot in common with normal people. They're also very busy, they do scan, and they really appreciate headings and having content that's easy to get to and read quickly. So plain language is for everyone. How am I doing on time? Am I okay?
You're good. You've got about 7 minutes.
Oh, wow. Flying through. Okay, so I have an example here. This was the Healthcare Associated Infections homepage a couple of weeks ago. And I've edited it since. So for the benefit of those on the phone, I'll go ahead and read this out loud. It says, Oregon has a number of national and state level activities focused on understanding and reducing the occurrence of healthcare-associated infections. These include mandated reporting of high-risk HAIs, validation of reported data, and a patient safety commission adopting evidence-based HAI prevention strategies aimed at reducing HAIs. Oregon also has multiple research projects to determine overall HAI prevalence, to make HAI surveillance easier for hospitals, and to monitor specific HAI pathogens. So I plugged that into that tool I showed you earlier, and that's a grade level 19.6. Does anybody have any ideas of how that could be improved? Any thoughts based on what we've talked about?
Bullets would be good.
Chunking, bullets. There's also like the HAI prevention strategies aimed at reducing HAIs. There's a few extra words that could probably be eliminated there.
Shorter sentences.
Yeah.
And even if you build in more white space, that's still not going to change the grade level, right?
Right. Well, yeah. Some of the bullets, like if you did bullets and broke it out, it could shorten the sentences structure, so the tool would pick that up. But yeah, just putting blocks in between wouldn't help. So I've edited it, and this is what we have up there now. It says, we work to understand and reduce healthcare-associated infections, HAIs, in Oregon. Here are some of the ways that we do that, : and then in bullets, collect statewide data on reportable HAIs, validate reported data, consult on outbreaks of transmissible pathogens in healthcare settings, conduct research projects that help us learn how many and what type of HAIs happen in Oregon, and make HAI tracking easier for hospitals. So I added bullets, I added white space, I shortened up the words. There's some personal pronouns, and it's now an 8.6 grade level. There's still some things I don't like about it. I really don't like transmissible pathogens, but you have to choose your battles and understand your audience. So to close, these are the plain language basics, and I hope that this was useful for you guys. Thank you.
I should mention, I know we're moving pretty quickly, but if we do have time at the end, we'll be able to do some questions as well. Becky is going to tell us a little bit about her work with WIC. I have the wrong thing up here. I don't know why this one's not showing.
All right. This one likes to be up here. It keeps coming back.
Yeah.
It's staying.
Sorry about that.
So, I have a background in history, and one of the things that I was really interested in school was historiography. Sort of like the way that history is written. Who it was written, for whom, like the perspective, who controls the narrative. I got really geeky on that stuff. And I think that that is something that can be really useful as we think about our public health programs. So if we're thinking about our public health programs and our policies, who were they built for and who were they built by? And how do we build in some flexibility for culture and preference and taste? So I'm going to talk a little bit using WIC as an example. I'm not sure how many of you are familiar with WIC, but it's a program that happens at this critical window, from pregnancy until a child turns 5. And this is a time of transition for families. They might not have as much income, they need a little bit more support. And this is also a time when children's brains and bodies need key nutrients for lifelong health. WIC provides link to foods that promote healthy development. We also support women in breastfeeding and provide links to community resources. And WIC touches a lot of families. About 40% of the infants in Oregon are on WIC. So I want to take a step back and think about how WIC started. And this is a picture of Marian Wright. Now she's Marian Wright Edelman. And she was the first black woman in Mississippi to pass the bar. She also interned with the NAACP. And later she would go on to found the Children's Defense Fund and help launch Head Start. And in 1967, she decided to take Senators Robert Kennedy and Joseph Clark on a tour of the Mississippi Delta to look at the extreme poverty that was happening there. And, well, not just poverty, but hunger. And this was happening not just in the South, but all over America. But in the South especially, African Americans were really locked into poverty with the sharecropping system. And families didn't have enough to eat, and so there were health consequences that could be long-term, like anemia and stunting and malnutrition. So this focus on the poor led to a national movement. There was a massive Poor People's March on Washington. There was an influential CBS special on hunger that really moved a lot of people. And Marian said this is a watershed moment. It's a coming together of white, black, Native American, and Latino poor, seeking jobs and adequate income and an end to hunger. And this is the context in which the WIC program was created. It was a time of advocating for the rights of poor people and people of color, and this was an attempt to really make health disparities visible and address them. And at this time, 83% of the US population was white and non-Hispanic. And yet, if we look at the kids in poverty, a minority of those were white. So the WIC program was created to address a lot of the disparities. And I also think it's worth noting that a lot of the policymakers and physicians that designed the programs were white. WIC is a program that's based on these priority nutrients. So sort of nutrients as the building blocks for healthy development, kind of like food as medicine to address some of these health disparities and hunger. So you have these critical ingredients for growth, like calcium, iron, protein, vitamin C, and these are especially important for pregnant women and young kids. So for a federal program, they had to be really specific about how these nutrients would show up in foods and how those foods would make their way out through health clinics, partly to make sure that that this would be standard and reliable, and that this would address malnutrition for families. So there are different ways to translate those nutrients into foods. And this interpretation was very specific to the United States in 1974, and really the foods that were widely available. So those nutrients, we have milk and cheese for calcium, iron in cereal, vitamin C in juice, and protein coming from eggs or peanut butter. So there are a lot of versions of what healthy food can look like all over the world. We have our pyramid or our plate. In Bolivia, Qatar, Japan, and Benin, those things might look really differently. And we could build a WIC program in any of these places, and it would look really different. It would be based on the local foods and those foods that are widely available in those countries. I think because WIC is so focused on food, it's a little bit easier to think about how it could be more culturally responsive compared to other programs like immunization or communicable disease. Food is so personal. It's about identity and values and tradition. And so it's really hard to have one set of standards that's going to fit everybody and feel good. But if you have to do it, this is what it might look like. So on the left is a food package that is currently offered for breastfeeding women, and on the right is a food package for a child. So the food package has evolved since 1972, and every 10 years it's updated. By whom, you ask? The National Academy of Sciences, Engineering, and Medicine. And they convene a panel of experts to look at what Americans, and specifically our population, is eating, what's healthy for development, and where are those gaps where WIC can really influence. And they do try to have an eye towards culturally responsive foods. So we have the foods from 1972, plus we also have whole grains, beans, yogurt, and fresh fruits and vegetables. Oh, and there's also an option for soy, like soy milk or tofu. And for fresh fruits and vegetables, that was the first time in which a food was not specifically tied to a nutrient. You can go to the grocery store and you can get bananas or you can get collard greens, and those look very different in terms of the nutrients that they're giving your body. So that was sort of like opening up a little space for families to make some choices. So WIC is a very prescriptive program. Again, a lot of federal regulations. And in 2009, when they added soy milk to the WIC food package and let families switch out their cow's milk for soy milk, they said, yeah, you can have soy milk, but it has to be exactly the same nutritionally as milk. It has to have protein, vitamin A, D, magnesium, potassium, riboflavin. Basically everything that's in milk needs to be in that soy milk. There was not a single soy milk that met that criteria. So some manufacturers did kind of change their formulas, and they built a soy milk that we could use. So there are some options now. But again, it's still switching one thing that is currently, that we eat in an American diet for something different. But these cultures that don't drink milk, they might not drink soy milk, or they might not do breakfast cereal. They might not use milk in the same ways that we do. So there are a lot of requirements, and what power do we have as a state to make it a little bit easier on families and more flexible? As a state, we can request a cultural substitution and say, this food really isn't meeting the needs of this population, but we have to find an alternative that is exactly the same nutritionally and cost neutral. It's kind of like needing to switch out a word and using a thesaurus, but you have to find a word that has exactly the same number of letters and vowels and consonants. So I would challenge you all to do that next time. So what else can we do? Well, every couple of years we update our food package as a state. And the areas in which we have some flexibility are cereals or juices. And so we survey participants to learn, within those categories, what would they want? And they're also really happy to offer up other suggestions of what they would want. And they might want whole milk instead of low fat, or they want more fruits and vegetables. And it's always hard because those are things that we can't change. So it's hard to ask if you can't change it. But we do try to offer people some options. So when I was on WIC with my first child, and I could get up to 5 gallons of milk every month, which is a lot of milk, and I don't drink a lot of milk. That's basically your full daily recommended amount. So if cow milk isn't your thing, you can get goat's milk or soy beverage instead, or you can replace some of it with yogurt or cheese or tofu. Again, it's still really based on that American diet and the American food patterns and what's available here, but it does give families more flexibility. We also have different options for whole grains. People can buy oats or brown rice, corn tortillas, bread, whole wheat pasta, even bulgur, which I think someone made some peanut butter bulgur waffles yesterday. So we try to build in some flexibility, but we also serve a population that speaks 50 different languages. So one thing we did, we worked with an OHSU dietetic intern, and we did 10 interviews with local WIC staff who are bilingual, bicultural, and are really working with families from all over the world. And we wanted to learn what they're hearing from families, and also what suggestions they have in working with those families. So we talked to staff who work with families from Latin America, the Middle East, and Vietnam. And we learned ways in which people are sort of reinventing the WIC foods. With families from the Middle East, they like to make popsicles with their milk, or they might make their own yogurt. They also don't use cold cereal, they buy hot cereal, and they might put it into a dessert, or they like to use it when someone is sick in the family. And for families from Latin America, they might make a beverage called avena caliente, which is a hot oatmeal beverage with milk. They might also use their juices in aqua fresca, and maybe adding cornflakes into meatballs instead of using it as a breakfast cereal. We have about 20 culturally specific stores across Oregon. They might be Southeast Asian or Latino stores, halal markets, kosher markets, and we really want people to be able to shop where they're comfortable. And the WIC foods might look very different in those settings. Those stores might carry foods that are not carried in the large supermarkets, and so that's really nice for our participants. So what else are we doing? We're trying to take a step back and look at our policies more broadly. For example, if we take the new definition of childhood obesity from 2010, the way that they identify obesity is with BMI percentiles, body mass index percentiles. And it's really most accurate for white kids. It's not as good for African American or Black kids. So it's more likely to identify them as having obesity, even when they don't have high levels of excess body fat. So we still have to use that national definition, but we can be a little bit more critical of it and be a little bit more aware of the population that we're working with. We're also paying attention to how stress might be related to risk for obesity. And maybe it's stress from poverty, or maybe it's race related. So if two children eat exactly the same foods, same level of physical activity, one may have been biologically and behaviorally programmed towards obesity due to stress. So we need to pay attention to issues like these as equity issues going forward, and how we treat people. All right, so we're trying to take a step back a little bit, think about how our systems are designed, especially with the demographics of the country shifting. And I just wanted to note that that expert panel put forward recommendations for the new WIC food package, and they really want to expand the fruits and vegetables. give people the option to have fruits and vegetables instead of juice, fruits and vegetables instead of baby food. So I really love that that window is opening wider and wider for families to give them more flexibility and help them have food that feels good to them. All right, thanks.
It's super hard to follow all those cute baby pictures.
I
I just
know.
want to put it out there.
A lot of those are local WIC participants too, which is cool.
They're adorable. Good morning. Happy Public Health Week. I don't know if anybody said it in the session yet, but there you go. Matt and Sheila and I are going to talk to you today about a collaborative project that's brought together staff from several sections of the State Public Health Division, as well as representatives of the Oregon Department of Education and community partners, including the Sexual Assault Task Force and the Oregon Coalition Against Domestic and Sexual Violence. And I think you'll hear some echoes of this equity theme that we've been developing through the week, particularly in terms of how equity seems to be at the bottom of every public health issue that we work on. So first to start, because we're public health and we love data, I'm going to start with a little bit of data. This is from the Women's Foundation of Oregon. And this statistic is that more than half the female population in Oregon has experienced domestic or sexual violence. This is a really sobering statistic. And let's also consider what this means for transgender people, for non-gender conforming people, and also for men and boys. Think about this level of prevalence of sexual violence in our society. So this is a picture of Tarana Burke. She's in the middle in the jeans jacket. She coined the Me Too movement and really got things started with the public conversation recently. And so sexual violence, because of that, is very much in the public consciousness right now. But if you've been paying attention, you'll also notice that the message frame is very much about victims and perpetrators. And that's a really important story. But for us in public health, we always take things up to the population level. And so thinking about the population level, and in this presentation, in this project that we're doing, we're taking that bigger public health framing and asking the question, how do we help to solve this problem as a society? And we know a couple of things that won't work. First of all, if we focus only on this victim-perpetrator storyline in the media, we need to go further upstream, and we need to address the sources of sexual violence where it can be prevented. We also know that we won't be successful if we consider sexual violence to be an isolated issue. So we probably all heard the word epidemic, and I'm gonna just read you the Merriam-Webster definition of this. It's a phenomenon affecting a disproportionately large number of individuals within a population, community, or region at the same time. And I think given the statistic we just saw, sexual violence really appears to fit this definition. But I'm going to introduce an even more helpful way to look at sexual violence. This is a word that our own Matt Laidler introduced to me, and it's the word syndemic. And if we think about sexual violence as part of syndemic, we think about it as part of a complex and interrelated set of overlapping and interacting outcomes and risk factors. So it's not just one issue, it's a whole number of issues all together. And so the syndemic that we're talking about today includes sexual violence, intimate partner violence, domestic violence, dating violence, bullying, as well as protective factors like healthy relationship development and what we're specifically talking about today, comprehensive, fact-based sexual health education. So we saw that Me Too slide. It's an awareness campaign, and awareness is incredibly important. But we also, in public health, know that awareness doesn't solve the issue. There are effective ways to actually help prevent sexual violence closer to the source. And comprehensive K-12 sex ed is an effective tool for doing that prevention work. Unfortunately, here in Oregon, we have really good legislation on the books that requires comprehensive K-12 sex ed. But we asked ourselves, is this law equitably implemented across the state? We're wondering about equity during Public Health Week. So it's a very germane question. So this question was actually the inspiration for our current project that Sheila and Matt are going to talk more about. We have two aims with this project. One is to evaluate statewide implementation of our comprehensive sexuality education law. And this is really looking at that place where sexual health education becomes sexual violence prevention. And we're also aiming to increase the reach and effectiveness of a comprehensive sex ed policy by developing resources. We're in the early stages of developing a toolkit that's going to assist in policy implementation. But today we're going to demo, Matt's going to show us an interactive map that links community level resources and policies and programs, as well as overlying data on the syndemic of sexual violence so that we can see this as a much more three-dimensional picture. So now I'm going to hand it over to Sheila. You have a tag team on this.
Hi, everybody. So before we talk a little bit about Oregon's sex ed policy, because I want to make sure everybody knows what that is, I want to ground us in the foundation of youth sexual health work in Oregon. And so a partnership of state agency folks and private partners almost over 10 years ago went out into communities and asked young people, in particular families and youth experts, what do we really need to be doing? What should we be focused on? And this is how we got to these 5 goals of the youth sexual health plan. What's important to call out is this was not just the Me Too movement that brought up consent and healthy relationships and the importance of sex ed. We've actually been saying this for a really long time. The goals of the youth sexual health plan, number 1, is that in Oregon we believe that youth use accurate information and well-developed skills to make thoughtful choices about relationships and sexual health. So that means that we have to give them information and give them skill development, and that should be happening in K-12 education. And then we have some public health goals around unintended pregnancy being reduced, STIs being reduced, and health inequities being eliminated. But the number 1 goal in here to be thinking about is that we had non-consensual sexual behaviors being reduced as part of our sexual health plan over 10 years ago. And that was from hearing from young people. Young people didn't want to hear about condoms and birth control and sex ed. They wanted to go much deeper, and that's reflected here. The other thing that happened almost 10 years ago is the sex education law was passed with then Governor Kulagowski. This is a picture of the signing that day. That is me much younger with my almost 1-year-old son at the time and some dear colleagues. And the sex ed law is a really amazing piece of policy in that it requires schools, elementary and secondary schools, to provide comprehensive sexuality education that is not only medically accurate, that's a really important piece, but also that understands that sexuality is a normal part of human development. The other thing that's happened since then, since 2009 with that bill, is there's been more legislation passed that specifically has interacted with our sex ed law, including the Healthy Teen Relationship Act, which is the green bar at the top. The Healthy Teen Relationship Act was passed in 2013, and it required grades 7 through 12 to start discussing teen dating violence within school instruction. In 2015, that was amended to also include domestic violence instruction. In 2015, another bill passed. That was Aaron's Law, that's the orange line. And that was child sex abuse prevention. What Aaron's Law did for Oregon is it actually requires education about child sex abuse prevention, grades K through 12, and it's one of only 2 bills that requires specific time in schools. So Aaron's Law requires 4 sessions, which equals 4 hours of instruction, K through 12, once a year, every year. It also requires training for personnel and information for parents. So what we did with these 3 laws is we really braided them all together for an Oregon approach to sex ed that is not just about condoms and birth control, but that brings in how we feel about ourselves, how we know about our identities, how we interact with each other, whether that's with friends, colleagues, loved ones, intimate partners, and really bring in the whole person. And we believe in Oregon that sexual health promotion is sexual violence prevention, right? So this Venn diagram, which was created, both of those, the last 2 slides, this is all from the Sexual Assault Task Force. They really create this piece of information that child abuse prevention, sexual health promotion, and sexual violence prevention all work together to make our communities safer and our kids happier. So Matt's gonna share more about the mapping project.
Thanks. And so I'm going to talk about the methods and results of our project to achieve the aims that Laura had talked about earlier. We began our project by building a foundational partnership by bringing together a work group that includes partners from the Attorney General's Sexual Assault Task Force, the Oregon Coalition Against Domestic and Sexual Violence, the Oregon Department of Education, as well as the Public Health Division Maternal and Child Health Program and Adolescent Health Program. We began collecting data in April of 2017 from approximately 197 of Oregon's school districts to determine which districts had a comprehensive sexuality policy and which had a comprehensive sexuality education written plan. We also collected data on the barriers and facilitators to developing a plan of instruction. And we started collecting data via phone and went to a web survey. So thus far, with the 33% response rate, we have found that 81% of the responding districts have a comprehensive sexuality education policy, and 44% have a written plan of instruction. So a lack of resources may make it challenging for some districts to implement or develop a comprehensive sexuality education plan or plan of instruction. And among those that responded, the districts indicated that the most needed resources were curriculum guidance. 58% of the districts indicated this as the most important resource. 49% indicated that teacher training was the most important resource. And 38% indicated that dedicated funding was the most important resource. So the data that we have collected will be added to an interactive map that we have begun to develop. And the purpose of the map is to present county-level data on the risk and protective factors, the outcomes and the policies and the resources related to sexual violence and its intersection to adolescent sexual health. So one of the resources we'll be developing is a toolkit that can be used by districts to develop and implement a comprehensive sexuality education plan of instruction. So I'm going to show you the map very briefly, and all the resources, all the data that are on the map currently, and those that will be added to the map, it's already publicly available data. We're simply trying to tie these data together around the intersection of sexual violence prevention and adolescent sexual health to provide a more complete picture than any one of these data sources alone could provide. So our map has a landing page which explains the origins of the map as well as the focus of the data. It also describes what the data can be used for, such as identifying community-level risk factors, protective factors, and outcomes, and resources related to sexual violence and its intersection with adolescent sexual health. Our map has indicators for sexual violence. So for instance, these data are from the Oregon Healthy Teen Survey, and an end user can click on these data to find out, for instance, the prevalence of sexual violence among 11th graders in any given county, as well as historic data for those indicators. Our map also has data on sexual abuse, teen dating violence, sexual behavior among teens, as well as sexually transmitted diseases. And our map also has data on pregnancy. So for instance, a user can click on a county to see the historical trends of pregnancy rates among teens in Oregon. So we've begun to add data on resources. So this layer shows sexual violence and domestic violence response resources by county. And the user can go to this to see the local resources that are available there. So this map is intended to be a platform that can engage local communities, that can document the current factors related to sexual violence and sexual health. It can be used to monitor trends and data, as well as potentially facilitate insight into the burden of sexual violence and its related factors. We will be adding new layers as we work through our project, including those related to the social determinants of health. The community that you're born into and the economic health the communities are born into alone can be a risk factor for sexual violence. So in conclusion, we're using a data-driven approach to sexual violence prevention. We believe trying to tie together the risk and protective factors, the outcomes, the policies and the resources at the local level can identify gaps in equity, as well as increase the awareness of sexual violence as part of this endemic. So although our project is still somewhat formative, our current efforts are to promote the map, to add new layers, especially those around social determinants of health, to present the socio-ecological context of adolescent sexual health, to develop a toolkit for school districts to develop a comprehensive sexuality education plan. We'll be planning to track changes in metrics so we know when our aims of the projects have been achieved. Thank you.
We have a few minutes for questions for any of the speakers today.
I had a question for Sheila. So when the students now say that they're not so interested in condom use or information about that, has the school districts, has the curriculum changed in what's presented?
Well,
Those
what I didn't
hours?
say is that there's one thing to have great policy right at the state level.
Right.
But we also know that policy is local control when it comes to schools, and there's 197 school districts. So the state can offer curriculum, can share curriculum, can give resources, but it's really up to local school districts to determine what sex ed looks like at the local level. And that's one of the things with this project is how do we help school districts get access to resources or training if needed. But maybe there's a lot of school districts that also don't even have a health educator, right? So there's a lot of kind of nuance and inequities around the state of who has the power and control to be able to do things and who also just doesn't have the resources or the space capacity.
About the task force, was the task force part of one of the bills, or was that just kind of formed out of just people coming together?
The agency, the task force?
Yeah.
Yeah, they've been around for a while, but so
Okay.
yeah, they're like the nonprofit partner who would work on the bills.
Okay.
Yeah.
Oh, okay. So they've just been around for a while.
Yeah, yeah. So it's not a task force.
Oh, okay. It's
task
the
force.
task force. Thank you.
I have a question. You said that about a third of the people that you contacted gave you back information. How does that fit into the map
So the data are not in the map yet. We'll be putting the data on the map.
for just those counties that you have?
Yeah, for the data that we collect, we'll be putting it on the map for those counties. And then tracking that over time.
Each school district.
Okay.
I have a question about did you find any significant differences in your data between, say, Multnomah County and Union County, or, something that's a very rural district? Have you noticed anything like that?
Yeah, there's a lot of differences in the data by county, certainly. And it really depends on the indicator. So we'd encourage people to go and look at the map and basically explore these different layers. And it's pertinent because we think that the use of the map could indicate where resources are most needed, and not every county has the same resources. So part of the equity issue is that how well comprehensive sexuality education is implemented may be dependent on the resources that are available in any given county. So definitely, yeah, there's differences. We'd encourage anybody to, look at the map and take a look at those differences.
Could you, could you repeat the question? Could you repeat the question?
So the data, are you looking at the data?
Could you repeat the question? 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 Could you repeat the question
Yeah.
We just need that last slide.
Yeah, we need the last slide, so to give you the URL.
I can add, if you add your name to the sign-in sheet, everyone will be emailed all the presentations that you attended as well, so you'll get a copy of this. I think this was the last slide, right? There we go.
I have a comment, not so much a question. First of all, thank you to all of the speakers. Everything was awesome. Love it. Good show. The health literacy is one of my favorite topics right now. And I'm kind of geeking out on that partially because of the context in which we work and how difficult health literacy is for our staff. And I think I have a theory on why. We, as the majority of people that are producing materials for the general public, are very well educated, and a lot of your identity as a well educated person is in the language that you use, and we don't want to give that up. And then we talk amongst ourselves, debating what words we're going to use and what words we can or can't give up, and we're the wrong people to even have discussion because we're trying to communicate with people that are in a different category of literacy. I found a webinar that's done by one of the national experts on this topic. She's a professor at Tufts University, and it's on iLearn. If you must go to iLearn, this is one thing I would really recommend you check out. And it's only like 50 some odd minutes long. The first 2 minutes are really quiet and hard to get through, but then this lady starts talking. I got distracted. I was doing something else, and I had to stop and go back and rewatch the thing. It's so good. But if you go to iLearn, I hope you can find it down in the version of iLearn. If you type in literacy, it should pop right up. And I really love it. If you go in and watch it, and everybody here, I want as much input on the stuff that's out there, but she mirrored everything that you said, and then there's a bunch of resources down at the bottom for other places you can go to get more information.
You can get a lot deeper into it. I recently went to a half-day training
Yeah.
on basically what I tried to do in 10 minutes. So.
But it's so important because the work that we do is brilliant, and then but communicating that to the people that need the information. So.
Yeah, and it's not very valuable if nobody either can't read it or can't understand it or can't even get to it in the first place.
Is the plain language resource that you put up there or that you used free and available? Or?
That website?
Yeah.
Yeah.
Okay.
Yep. Just type it in.
Thank you.
Thank you all.